Welcome back to the deep dive. Today we are undertaking a pretty monumental task.
We certainly are.
We're cracking open the orthopedic section of one of the most respected surgical texts in the world. We're going deep into Chapter 39, the hip, from the 28th edition of Baily Love's Short Practice of Surgery.
And this is, it's so much more than just a chapter on bones and joints. It's really a synthesis of biomechanics, radiology, and some incredibly intricate surgical decision-making.
Exactly. And our mission today is really for you, the listener, the learner.
Right. We have to be very clear about this. We are not trying to replace the book. You absolutely must go and read the primary text.
You have to.
But what we're doing here is creating a kind of interpreted roadmap. Think of it as a rapid revision aid, maybe a ready reckoner. It's designed to anchor these complex clinical concepts and, the numbers you need to remember for them to stick.
We want to pull out those essential clinical anchors, the so what, behind all the mechanical facts. So when you're asked about a complex hip issue, we want the anatomy, the force calculations, the whole management pathway to just snap into place.
We're trying to cut through the density of the text to give you the most memorable, high-yield insights.
So to keep us organized, we've structured our deep dive around the chapter's own core objectives. First, we'll start with the foundational anatomy and biomechanics, really focusing on the clinical implications.
Then second, we'll get into the common adult pathologies. We're going to focus on avascular necrosis AVN and femoroacetabular impingement, or FAI.
After that, we'll dive into the real engineering principles, the materials, the complications of a total hip replacement, or THR.
And finally, we'll wrap up by discussing the realities of post-op care and what happens when things go wrong, which is revision surgery.
Okay, so let's start at the very beginning, the hip. It's often called a high-performance ball and socket joint. It's where the smooth head of the femur meets the acetabulum, which, I just love this word, comes from the Latin for little vinegar cup.
It's a great description, isn't it? And that ball and socket structure is really the key to its whole purpose, which is this amazing combination of a huge range of movement with, at the same time, exceptional stability.
It's a paradox almost.
It is. I like to think of the hip as a fortress. It's built incredibly strong because of the immense forces it has to deal with every single day, and its stability comes from both its passive architecture and its active muscular engine.
Let's unpack that architecture first. What are the seat belts, the static stabilizers that keep that femoral head locked so tightly in the vinegar cup?
Well, the main static stabilizers are the joint capsule itself and then these incredibly powerful ligaments. So anteriorly, you have the thick iliofemoral and pubofemoral ligaments. They're like reinforced steel bands.
Yeah.
And then posteriorly, there's the ischiofemoral ligament.
But the source really emphasizes one structure that's maybe the most critical for the long-term health of the joint. And it's often the first thing to get damaged.
You're talking about the labrum.
The labrum. It's that fibrocartilaginous ring around the rim of the acetabulum.
Yes, and it does two things. Everyone knows the first one. It deepens the socket, which, adds to the bony stability. But its second function is arguably far more critical.
Which is?
It acts as an absolutely essential fluid seal. This is a concept that you have to anchor immediately.
Okay.
The hip joint is like any high-performance machine. It relies on what's called hydrostatic pressure lubrication. The labrum maintains this perfect fluid-tight seal, which ensures the synovial fluid creates this pressure cushion between the cartilage surfaces.
Wow. So if that seal is broken, say by a labral tear, which we see in FAI, what is the immediate consequence for the joint? What happens?
It's catastrophic. It really is. It's like losing oil pressure in an engine.
Oh, great analogy.
When that fluid seal breaks, the whole lubrication mechanism just fails. The load-bearing surfaces of the articular cartilage, they lose their protective fluid film. And the result is incredibly high point loading, which causes rapid cartilage wear and, eventually, total destruction.
So a labral tear isn't just a tear. It's a ticking clock for early osteoarthritis.
It's often the very first step. It's a major harbinger of early OA.
That's a brilliant way to put it. Okay, so once we get past that static architecture, we move to the engine room, the dynamic stabilizers.
Right, the muscles. The dynamic stabilizers are all the muscles that cross the joint, providing control and power. So you've got the short external rotators and the huge gluteus maximus posteriorly.
Okay.
The deep iliopso is at the front, and then the really critical hip abductors on the side, the gluteus medius and minimus. All of these muscle groups have to contract together synergistically to control every movement, especially when we're bearing weight.
Okay, before we get into the stresses of weight bearing, we have to talk about the blood supply. Because if the entire fortress relies on one single lifeline, we need to know what it is.
We do, because failure here leads directly to major pathology.
So what is it?
You absolutely must remember the medial circumflex femoral artery.
The medial circumflex femoral artery.
It provides the vast, vast majority of the blood supply to the femoral head through its little retinacular branches. Now, there is a small contribution from the artery of the ligamentum teres, but it's often inconsistent.
Not enough to save it.
Not enough on its own, no. The medial circumflex is the primary lifeline. If it gets compromised, whether that's through trauma or some kind of microvascular damage, that is the immediate precursor to a vascular necrosis.
Okay, so now let's talk about the punishment this joint takes. The biomechanics. The source material, specifically Summary Box 39.2, outlines forces that. I mean, they're genuinely hard to believe.
The magnitude of these loads is what dictates everything. The success or failure of the hip. People assume the force is, equal to their body weight, but it's not even close.
Right. Just lifting your leg while you're lying down is already what?
1.5 times your body weight across the joint, just for that simple movement.
And here's the key figure, the one that defines daily function. When you stand on one leg, which you do with every single step you take, the force on that hip joint jumps to
3 times your body weight.
3 times. It's incredible.
It is. And if you start doing dynamic activities, running, jumping, heavy lifting, those peak forces can soar to as much as 10 times your body weight.
10 times. That 10x multiplier is the number you have to remember. That's the extreme pressure this joint has to withstand routinely.
It really is.
But I have to ask, why? Why does standing on one leg generate triple the force? It doesn't seem intuitive.
Yeah.
Shouldn't the force just be your body weight on that one leg?
It's a great question, and it's a mechanical equilibrium problem. It relates directly back to those dynamic stabilizers we just talked about.
The abductors.
The abductors. When you lift one foot off the ground, your entire body's center of gravity wants to pivot and drop your pelvis down toward the unsupported side.
Right, you just tip over.
You would. So to counteract that massive gravitational lever arm and keep your pelvis perfectly level, the abductor muscles on the weight-bearing side, the gluteus medius and minimus, they have to contract with tremendous force.
So they're fighting a long lever arm with a very short lever arm.
That's the perfect way to describe it. And because the abductors attach so close to the hip joint, they need to generate this incredibly high tension force to produce the necessary stabilizing moment. And that high tension force from the muscles adds to the body weight force.
So it's body weight plus muscle force.
Exactly. And the sum of those forces is the total compressive load across the joint surface, which results in that 3x body weight anchor.
That makes perfect sense. And it also explains why this very principle is the basis for a critical clinical test.
It is the absolute foundation of the Trendelenburg test.
Explain that.
When you ask a patient to stand on their affected leg, you are directly testing whether those abductor muscles can generate that 3x force needed to keep the pelvis level. If they're weak, or if the joint itself is unstable, the pelvis drops towards the unsupported side.
And that's a positive Trendelenburg sign.
That's a positive sign. It is a direct visual manifestation of those biomechanical forces at work.
Okay, fantastic. Let's pause for a quick check-in question for you, the learner. We've covered the fundamentals, the incredible demands on this joint. Can you recall the primary blood supply to the femoral head and that eye-opening force multiplier when you're just standing on one leg?
Take a moment. If you didn't instantly recall the medial circumflex femoral artery and 3 times body weight, we'd really recommend a quick rewind of this first section.
Absolutely. Solidifying those 2 facts is so crucial before we move on to the pathologies that result when these systems fail.
It really is.
Okay, so key takeaways for section 1. The labrum is a vital fluid seal. The medial circumflex femoral artery is the lifeline. Forces are massive 3x standing, up to 10x maximum. And the Trendelenburg test is a direct assessment of that abductor strength.
All right, so now we can move into the first major adult pathology that results from that lifeline failing, a vascular necrosis, AVN.
And you used a great metaphor for this earlier, the city power failure.
I like that one, yeah. It's an interruption of that arterial blood supply to the femoral head. It leads to localized bone death osteonecrosis, which, inevitably results in the bone collapsing, and then severe secondary osteoarthritis.
The source gives a pretty comprehensive list of causes, both primary or idiopathic and secondary. But we should focus on the anchors, right? The common causes a surgeon will see most often.
Absolutely. The full list includes things like sickle cell disease, hemoglobinopathies, Caisson disease, the Benz lupus, Gaucher's disease, chemotherapy. It's a long list. But clinically, the priority has to be on the two most frequently implicated secondary causes: long-term steroid use and chronic alcohol excess.
So if a patient has that history and they present with new hip pain,
AVN has to jump to the absolute top of your differential diagnosis.
do we have a good understanding of the mechanism? How do steroids and alcohol actually cause this power failure?
It's multifactorial, but a common pathway seems to involve the microcirculation. High-dose steroids can lead to things like fat emboli or hypercoagulability, causing these tiny little microthrombi that block the small vessels.
Okay, and alcohol.
Chronic alcohol use often results in hyperlipidemia, which can cause a similar microvascular occlusion. It also seems to increase the marrow pressure inside the femoral head, which basically strangles the blood supply from the inside out. It's a very progressive, insidious process.
Let's talk about the patient profile. Who is the typical person who presents with AVN?
It disproportionately affects younger individuals, typically men aged between 35 and 45.
Which is a huge distinguishing feature from primary OA, right?
Mm-hmm.
That usually affects an older demographic.
A critical difference. And what's really startling is that it's bilateral in over 50% of patients.
Wow.
Which means if you diagnose it on one side, you have an obligation to actively investigate the other hip.
And clinically, the progression is insidious. It starts out asymptomatic.
Completely silent in the early stages, which is the real danger. As the disease advances, the patient starts to develop this deep groin ache and a characteristic antalgic limp, a painful limp.
And on examination.
They'll eventually show a limited range of movement, especially internal rotation, and you might find a positive Thomas's test, which indicates a flexion-contracture of the hip.
Okay, now let's get into the critical radiological signs, because timing is everything with this disease. What does an X-ray show, and how does that story of collapse unfold?
Well, in the very early stages, the X-ray can be completely normal.
Which is a major pitfall.
A huge pitfall. As the pathology progresses, the first subtle sign might be an increased density or sclerosis in the femoral head. The bone is dying and becoming brittle. But the true pathognomonic sign, the one that indicates imminent structural failure, is the crescent sign.
Okay, let's define that. What does the crescent sign actually represent? What's happening in the bone?
It signifies subchondral bone resorption. It's this thin radiolucent line that forms just beneath the articular cartilage. It's literally the fracture line where the dead segment of bone is beginning to separate from the living part of the femoral head.
But once you see the crescent sign,
you know that the structural integrity is irreparably compromised. Collapse is about to happen or is already happening. After that, you'll see flattening and irregularity of the head, which means you're in the full segmental collapse stage.
this brings us to the key diagnostic anchor. Because as you said, X-rays are often too late. So how do we catch AVN in that pre-collapse asymptomatic stage?
Magnetic resonance imaging is mandatory. The MRI is specified as the most sensitive and specific investigation for AVN, period.
Why is it so much better?
Because it can detect the subtle changes in bone marrow edema and signal intensity long before you'd ever see bone density changes on a plain X-ray. So if you have a high-risk patient steroid user, heavy alcohol use, and they report even vague, non-specific hip discomfort, you go straight to MRI.
You don't wait for the X-ray to become positive.
You don't. You've already missed the boat by then.
So to manage this, we need to stage it. The source talks about Steinberg's classification, which goes from stage 0 to 6. What are the key stages we really need to anchor for clinical decision-making?
Steinberg's is all about defining that window of opportunity. So stage 0 is asymptomatic, normal imaging. Stage I, you see abnormalities on the MRI only.
Okay.
Stage 2 is when you see changes on the X-ray, like that sclerosis, but this is critical. The spherical shape of the femoral head is still maintained. This is your surgical window of opportunity.
In stage 3.
Stage 3 is defined by the appearance of that crescent sign. That's the start of subchondral collapse. By stage 6, you're at the end stage, with complete joint space obliteration and severe arthritis. The real dividing line for treatment is between stage 2 and stage 3.
Let's use that staging in a case study. Imagine you're reviewing a 40-year-old male, a previous heavy drinker. He's cut back recently, but now presents with this intermittent dull ache deep in his left groin. No history of trauma. His weight-bearing X-rays, taken 2 weeks ago, were reported as normal.
Okay.
Based on what we've just discussed, what is the required next step, and why is timing so critical here?
The required next step is an urgent MRI of the hip, no question. The history alone, the young male, the high risk factor with alcohol that demands a high suspicion. The normal X-ray means nothing.
Right. It can easily be stage 1 or 2.
Exactly. If that MRI confirms AVN but shows the head is still perfectly spherical, we're in the preservation window. We can potentially save his hip. If we wait and that head collapses to stage 3 or 4, our surgical options shrink dramatically from preservation to replacement.
And that sets up the management strategy perfectly. Preserve versus replace.
That's the entire game.
Yeah.
And the source stresses that conservative treatment is, well, it's rarely successful once the disease is really established. Treatment is dictated entirely by whether that femoral head is structurally intact.
So in that pre-collapse stage, stage 1 or 2, what are the surgical options?
The goal is revascularization and preservation. We want to keep the patient's native joint. The most common procedure is called core decompression.
Which is what, exactly?
It's essentially drilling a channel into the femoral head. The goal is to relieve that dangerously high intraosseous pressure, improve the microcirculation, and hopefully reduce pain. This can be done with or without various forms of bone grafting to physically support the weakened bone.
But once the bone has collapsed, once that crescent sign appears and the head is no longer round,
Then preservation is much, much harder. We can try to reorient the load-bearing area using a femoral osteotomy. We basically cut the bone and rotate the healthy segment of the femoral head into the main weight-bearing zone.
but if the damage is too advanced,
Then the path moves directly to total hip replacement.
okay. Key takeaways for Section 2. AVN is common in young adults, often linked to steroids or alcohol. MRI is mandatory for early diagnosis, and management hinges entirely on staging. Pre-collapse means preservation, like core decompression. Post-collapse means reorientation, or, more likely, replacement.
So having covered AVN, let's move to a pathology that is now recognized as one of the leading underlying causes of secondary OA in young adults. That's femorosacpular impingement, or FAI.
FAI. So this is a mechanical conflict, a repeated collision between the femur and the acetabulum during normal hip movement, and it's a huge cause of pain in young, active people.
A huge cause. And the source describes two primary types, though they often coexist.
Let's start with type 1.
Type 1 is CAM FAI. This is a femoral abnormality. You can imagine the femoral head isn't a perfect sphere. It has an abnormal bony prominence, or a bump, at the head-neck junction.
And when the hip moves, that bump just jams into the socket rim.
It jams right against the acetabular rim.
And how do we quantify that bump radiologically? There's a specific measurement.
We measure its severity using the alpha angle. This angle measures how much the head deviates from a perfect sphere. If the alpha angle is greater than 55 degrees, it's considered abnormal CAM morphology.
And the source mentions a specific X-ray view to see this best.
Yes, the 45-degree lateral Dunn view. It's really important for detecting those subtle CAM deformities on the anterior part of the femoral neck.
Okay, so that's CAM. Type 2 is pincer FAI, which is an abnormality on the socket side.
Right. Pincer refers to an overcoverage of the femoral head by the acetabulum. Either the socket is just too deep or it's angled backwards, which we call retroversion. The end result is that the acetabular rim pinches the femoral neck.
The pincer effect.
Exactly. It pinches the neck against the labrum.
And pincer impingement is diagnosed with a different measurement.
It is. We use the lateral center edge angle, or LCA. This measures how much the acetabulum covers the femoral head from the side. The normal range is 25 to 40 degrees.
So for pincer, the LCEA would be
Over 40 degrees. That indicates pincer overcoverage. The socket is too deep.
So the core problem here is this repeated microtrauma. It usually happens during deep hip flexion combined with internal rotation, right, like squatting or certain sports movements.
It's a classic mechanism.
And what structure gets damaged first in that collision?
The initial damage always occurs at the laprochondral junction, right where the labrum meets the articular cartilage. This repeated jamming causes labral tears, and then eventually the cartilage starts to peel away.
Which leads back to early cartilage destruction.
It does. Clinically, these patients present with chronic groin pain, often related to specific movements, and they have restricted range of motion, particularly internal rotation when the hip is flexed up to 90 degrees.
So beyond the plain X-rays for the bony assessment, what else do we need to see the soft tissue damage?
MRI is essential here. You need it to evaluate the labrum and the chondral surface. We also often rely on 3D CT scans, not just for diagnosis, but crucially for surgical planning.
Ah, so you can map out the bone in 3 dimensions.
Exactly. It gives the surgeon an accurate 3D map of the bony deformity so they can plan precisely how much bone they need to remove or reorient.
Okay, so if FAI is a problem of overcoverage, we have to talk about the opposite problem, hip dysplasia in the adult.
Dysplasia is a problem of undercoverage. The acetabulum is too shallow and too steep, so it fails to adequately cover the femoral head.
And this leads to excessive point loading on a very small area of cartilage.
Exactly, which causes premature wear and tear.
And radiologically, how do we confirm dysplasia?
We use the same measurement, the LCEA, but the finding is the complete opposite of pincer. Dysplasia is diagnosed when the LCEA is less than 20 degrees. The femoral head is basically exposed. You might also see an acetabular index, or tunnus angle, of greater than 10 degrees, which suggests the socket is too steep.
So dysplasia is almost a guaranteed path to early OA. Management here must be about preserving the joint if at all possible.
It is. For moderate dysplasia without severe arthritis, the key preservation procedure is the periacetabular osteotomy, or PAO.
And that's where you surgically reorient the entire socket.
That's right. You surgically detach the acetabulum and rotate it to a position where it achieves better coverage of the femoral head. But once severe arthritis is set in, the decision is forced back towards a total hip replacement.
It's important to stress, though, that not all hip pain actually comes from inside the joint itself. The source reminds us of several extra-articular causes.
And this is really important for the differential diagnosis. You have to consider things like iliopsoas impingement, where the tendon gets inflamed, subspine impingement, ischiofemoral impingement,
Which causes that deep buttock pain.
yes, from compression of the quadratus femoris muscle, and deep gluteal syndrome, which is often a form of sciatic nerve entrapment in that region.
And what about the very common, often audible, snapping hip syndromes?
We differentiate between internal and external. The internal snapping hip is typically the iliopsoas tendon snapping over the front of the hip capsule. It's a sound that's heard and sometimes felt right in the groin.
And sternal.
The external snapping hip is the iliotibial, or IT band, snapping over the greater trochanter on the side of the hip. While they're often benign, they can definitely require treatment if they become painful.
Okay, so key takeaways for Section 3. FAI is a mechanical conflict. CAM is measured by the alpha angle, pincer by the LCEA. Dysplasia is the opposite, it's undercoverage. And always remember the extra-articular syndromes when you're investigating groin pain.
So we've established that these complex pathologies like FAI and dysplasia often need pretty invasive surgery to try and preserve the joint. But given all the differential diagnoses we just listed and how deep the joint is, there's a critical diagnostic step that has to come before any major operation.
Right, and that brings us to the diagnostic hip injection. Why is this considered so essential before you commit someone to a major preservation surgery?
Because the differential for groin pain is just so wide, the pain can be referred from the back, from the abdomen. So injecting a mix of local anesthetic and steroid directly into the joint capsule under an image intensifier is the only way to confirm with certainty that the pain is truly intra-articular.
So if the pain immediately disappears after the injection,
You've confirmed the source, it proves the joint itself is the pain generator.
and the source emphasizes that it's not just diagnostic, it's also prognostic.
That's right. The response is a critical prognostic tool. If a patient gets zero pain relief from a well-placed intra-articular injection, you have to seriously question your diagnosis and probably reconsider surgery. A positive response helps justify these complex, expensive procedures.
So once the pain source is confirmed, we can look at the techniques, starting with arthroscopy. You mentioned it's technically challenging.
Hip arthroscopy is very difficult. The joint is deeply recessed. You're navigating through a thick muscular envelope. It has a steep learning curve for surgeons.
But the applications are huge.
They are. You can treat labral tears. You can address FAI by shaving the cam or pincer bump. You can remove loose bodies. And all of it is minimally invasive with a relatively quick recovery.
But if the problem is more fundamental, a bony malalignment, we have to move beyond arthroscopy to an osteotomy. And the goal here is all about redistributing load.
Exactly. The purpose of any osteotomy, whether it's on the femur or the acetabulum, is to surgically cut and fix the bone in a new position. The whole point is to eliminate that dangerous point loading and redistribute the weight-bearing forces evenly across a larger, healthier area of cartilage.
Who is the ideal candidate for an osteotomy? This is a high-stakes, joint-saving procedure.
The ideal candidate is defined by three key things. A young patient, generally under 40 or 45, a good range of movement in the hip, and most critically, minimal degenerative changes. The joint has to be worth saving.
And the indications would be things like dysplasia or early AVN.
Exactly. Dysplasia, the after effects of childhood conditions like Perthes disease, early AVN, and early OA in a young person that's caused by FAI.
Given the complexity of realigning a joint in 3D, the source really highlights the role of modern surgical planning.
Oh, it's non-negotiable now. We rely heavily on 3D CT scans, sometimes even 3D printed models of the patient's own pelvis, computer navigation, and even robotic assistance to accurately plan and execute the precise angle changes we need.
A millimeter can make all the
A
difference.
single millimeter of error in a PAO can completely undermine the entire goal of the operation.
So if preservation fails, or if the patient is older and the joint is just too worn out, we arrive at the most common endpoint, osteoarthritis, OA.
OA, the degenerative endpoint. It's divided into primary and secondary. Secondary OA is when it follows a known insult trauma, AVN, untreated dysplasia, or FAI.
But what's really fascinating, and it links right back to Section 3, is this idea that FAI is actually the cause of many cases we used to just call primary OA.
That is the emerging consensus that's referenced in the chapter. It suggests that a lot of people who develop what looks like wear and tear OA in their 50s or 60s actually had subtle cam or pincer deformities their whole lives.
And those deformities cause slow, progressive damage over decades.
Exactly, resulting in what looks like idiopathic OA, but is actually the endpoint of a decades-long mechanical failure.
Clinically, what is the most reliable presenting feature of hip OA? What do patients complain about?
Groin pain and limitation of movement. The pain is typically deep in the groin, and it can radiate down the thigh. But here is the major clinical pitfall for you to remember. That pain often radiates all the way to the knee.
So they present with what they think is knee pain.
Sometimes isolated knee pain. A clinician must always examine the hip if a patient's knee symptoms don't quite fit the knee pathology.
And how does the progression look?
It's an unrelenting progression. It starts as activity-related pain, then it becomes pain at rest, and eventually the patient struggles with unrelenting night pain. That's often the final straw that makes them seek surgery.
And functionally?
Functionally, they report difficulty with anything that requires flexion and rotation. Putting on socks, getting into a car, cutting their toenails, all those simple things become impossible.
On examination, besides the limp, what is the most consistent physical sign of OA?
The earliest and most consistent physical sign is the loss of internal rotation. That's due to the osteophytes forming and the capsule tightening up. You'll also look for the classic positive Trendelenburg sign and the modified Thomas's test.
Okay, let's anchor the 4 radiological hallmarks of OA. These are non-negotiable. You have to recognize them on an X-ray.
The 4 signs. First, reduced joint space, which signifies the loss of the cartilage. Second, subchondral sclerosis, which is increased bone density right under the cartilage where the stress is highest.
Okay.
Third, subchondral cysts. These are little fluid-filled cavities that form as joint fluid gets forced into the stress bone. And fourth, osteophyte formation, the bony spurs that form at the joint margins.
Before surgery, of course, non-operative management is essential. What are the pillars of conservative treatment?
NSAIDs, regular low-impact exercise, physiotherapy, weight loss, all standard, but the most crucial piece of mechanical advice goes right back to our biomechanics discussion. Patients must be advised to use a walking stick or a cane in the opposite hand to the affected hip.
Why is the opposite hand so critical? Let's connect it directly back to Section 1.
When you hold a stick in the opposite hand, you're creating a new lever arm that helps to keep the pelvis level. This effectively does the job of the painful abductor muscles on the affected side.
So you're taking the strain off those muscles.
You're taking the strain off the muscles, which means you significantly reduce the overall force going through the hip joint. You can reduce that 3x body weight load by 50% or more. It's simple physics applied directly to pain relief.
Fantastic. So when those measures fail, surgery is indicated. The options are
Arthrodesis, which is fusion, osteotomy, realignment, or overwhelmingly the most common option, total hip replacement.
right. Key takeaways for Section 4. Diagnostic injections confirm the pain is intra-articular. Osteotomies save the joint in young patients. OA presents with groin pain and lost rotation. And you must tell patients to use a walking aid in the opposite hand.
Okay, before we celebrate the massive success of THR, let's quickly touch on arthrodesis, or fusion. It is mentioned as an option, but it's exceptionally rare now.
Fusion. It makes the joint painless, but completely immobile. Who is the very specific, very narrow demographic where this might even be considered today?
It's reserved for a tiny cohort of very young patients, maybe under 30, who have extremely heavy manual jobs. Jobs where the loads are so high that any mechanical replacement would just fail prematurely.
And the goal is to fuse it in a functional position.
Yes, ideally about 30 degrees of flexion, 15 degrees of external rotation, and a little bit of abduction.
But the drawback is severe, isn't it? It's all about compensatory mechanics.
The drawback is the inevitable long-term degenerative change in the adjacent joints. By eliminating motion in the hip, you force successive compensatory movement onto the knee, the other hip, and the lower spine.
So the source says that degeneration in those joints is not a complication.
It is the rule. It's a guaranteed outcome because those joints have to take up all the slack from the missing hip motion.
Which really highlights why total hip replacement is one of the most successful operations in history. The volume is just staggering, over 95,000 a year in the UK alone. What are the success rates?
The outcomes are phenomenal. In the Best Modern series, you're looking at 95% of primary THRs still being fully functional at 10 years and 85% at 20 years.
That's incredible.
It's transformative. It offers life-changing improvements in pain, mobility, sleep, everything.
So to get that kind of success, the source details the principles of an ideal joint replacement. It's a great piece of surgical engineering theory.
It is. The ideal implant has to satisfy this long list of requirements. It has to be biocompatible, perfectly fixed to the bone, mechanically stable, offer a wide, friction-free range of motion.
And critically, the bearing surfaces.
Critically, the bearing surfaces must create minimal friction and, most importantly, minimal wear particles. The materials can't be toxic, and the whole thing should ideally outlive the patient.
Let's talk about that key challenge. Wear. The Charlie Revolution gave us the original gold standard, the hard-on soft bearing.
The Charlie design paired a hard metal head with a soft, high-density polyethylene socket. This low-friction bearing gave remarkable longevity, and it's still the preferred option for older, lower-demand patients, say, over 70.
But what is the long-term, predictable failure mode of that polyethylene surface?
Yeah.
We need to define that process.
The failure is both mechanical and biological. The polyethylene wears away very slowly, producing these tiny microparticles.
Okay.
These particles are then ingested by macrophages, which are immune cells in the surrounding tissue. This kicks off a chronic inflammatory response. This inflammation then stimulates cells called osteoclasts to start destroying and resorbing the bone tissue around the implant.
And that process is called?
That process is called osteolysis, and this osteolysis eventually leads to the clinical picture of aseptic loosening. The implant becomes loose because the bone holding it has been eaten away.
So the search for better options for younger patients led surgeons away from polyethylene to hard-on-hard alternatives.
Correct, ones with much lower wear rates. The first of these is ceramic on polyethylene. This combines the good old polyethylene socket with a much harder ceramic head, which significantly reduces wear. This is often the go-to choice for middle-aged patients, generally under 70.
And the option with the absolute lowest theoretical wear rate.
That would be the ceramic on ceramic bearing. This pairing produces the least amount of wear particles, so it offers the best long-term potential for young, active patients.
But there are trade-offs.
Always. They're expensive. There's a small but very real risk of the ceramic component fracturing, and they are notorious for sometimes causing a high-pitched, audible squeaking with certain movements.
Squeaking?
Yes. And while it's not medically dangerous, it can severely impact a patient's quality of life.
And what about metal on metal? They were popular for a while.
They were. They offered a low wear rate, but the wear particles they produced were different. They were much, much smaller nanoparticles of cobalt and chromium. And these metal ions caused a severe local tissue reaction known as adverse reaction to metal debris, or ARMD.
And they were very sensitive to positioning.
Extremely. If they weren't placed perfectly, they failed rapidly, causing huge amounts of osteolysis and tissue damage. Due to significant failures and recalls, this bearing surface is now very rarely, if ever, used.
Okay, let's shift from bearings to fixation. Cemented versus uncemented. How do we stick the implant to the bone?
The traditional method uses polymethyl methacrylate, or PMMA, bone cement. This is the cemented approach.
Yeah, we have to use that analogy again. PMMA acts as a grout, not a glue. Explain that.
It's a critical distinction. If it were a glue, it would rely on chemical adhesion, which is weak in a biological environment. As a grout, we rely on mechanical interdigitation.
So you're forcing it into the bone.
Exactly. The cement is forced under pressure into the porous matrix of the trabecular bone, and it hardens quickly to create this tight mechanical lock. It gives excellent long-term outcomes, it's cheap, and it's great for older patients with softer osteoporotic bone.
But it has its own specific risks.
It does. Three main ones. First, the polymerization of the cement is an exothermic reaction. It releases heat, which can cause thermal injury to the bone. Second, it's notoriously difficult to remove during a revision.
And the third?
And third, most critically, the pressurization of the cement can force air, fat, and cement bits into the circulation, which can sometimes cause a sudden, acute drop in blood pressure during the operation.
And conversely, the uncemented approach relies on a biological process.
Yes, biological fixation. Here, the prosthesis has a rough, porous surface, sometimes coated with an osteoconductive agent like hydroxyapatite. The bone is encouraged to grow directly into these pores, achieving a stable, long-term bond called osseointegration.
But what are the trade-offs for that?
Well, the uncemented component requires a perfect press fit into the host bone, which increases the risk of fracturing the femur during surgery. It's more expensive. And if it ever fails, removing a biologically fixed implant is significantly more difficult and destructive to the bone.
Okay, time for a check-in question for you at home, testing these engineering choices. Imagine a 45-year-old highly athletic patient needs a hip replacement. If longevity is the single most important factor, which bearing surface combination is the standard choice, and what are its two most critical drawbacks?
The preferred choice for maximum longevity in that patient is ceramic on ceramic. And the two critical drawbacks are the risks of fracture and squeaking. If you didn't get those, just pause and quickly review the bearing surfaces.
Okay. Having covered the components, let's quickly discuss the surgery itself. The source lists various surgical approaches: posterior, anterolateral, anterior. For the listener, what's the key difference in terms of post-operative precautions?
Well, the approach dictates which tissues are divided or spared, and that defines the dislocation risk. The common posterior approach requires dividing the short external rotators, so the post-op risk is dislocation if you combine hip flexion with internal rotation.
The don't cross your legs precaution.
That's the one. The anterior approach avoids those posterior structures, so the precautions focus on minimizing extension and external rotation. But regardless of the approach, the goal is always the same: anatomical restoration. Correct leg length, correct offset, correct center of rotation.
Post-operatively, patients are mobilized very quickly now with short hospital stays. What is the one critical post-op complication we have to manage aggressively?
Venous thromboembolism, or VTE. That covers deep vein thrombosis, DVT, and pulmonary embolism, PE.
And orthopedic surgery, especially lower limb arthroplasty, carries a very high risk of VTE.
Why is it so high after a THR?
It relates directly to Virchow's triad. You have vessel wall injury from the surgery itself, you have blood stasis from post-op immobility, and you have hypercoagulability because of the surgical stress response. A resulting PE can be fatal, so prevention is absolutely mandatory.
What are the combined measures for VTE prevention?
It has to be a multimodal approach. Mechanical methods like foot pumps and TED stockings, good hydration, early mobilization. But crucially, it includes chemical thromboprophylaxis, blood thinners.
Yes. Low molecular weight heparin, warfarin, or the newer oral anticoagulants, and this has to be continued for a prolonged period, typically 4 to 6 weeks after the surgery.
Okay, now we have to address implant failure, the dreaded revision THR. The indication is failure, often from loosening. We need to clearly distinguish the mechanisms of aseptic versus septic loosening.
Aseptic loosening is that long-term, sterile, mechanical failure we talked about. It's caused by the biological response to the wear particles. It's purely inflammatory, results in osteolysis, and presents clinically as pain, primarily on weight bearing.
And septic loosening.
Septic loosening is infection. Periprosthetic joint infection, or PJI. This is the more feared complication because it can be very subtle and low grade.
And it's often caused by less aggressive bacteria.
Exactly. Often slow multiplying organisms like Staphylococcus epidermidis, which are very clever. They hide themselves by creating a protective slime layer on the implant called a glycocalyx biofilm.
And if the infection is low grade and hiding in a biofilm, how does that affect the diagnosis?
Yeah.
The usual markers might not be very high.
That's the problem. The systemic inflammatory markers like CRP or ESR might be only mildly or equivocally elevated. Definitive diagnosis is complex. It relies on things like the Musculoskeletal Infection Society criteria and absolutely requires a joint aspiration and biopsy to try and culture the pathogen.
Let's use a final case study to contrast the management. Patient A is 70 years old, 15 years post-THR, and reports increasing groin pain only when hiking. Patient B is 6 months post-THR has some recurrent mild wound drainage, and a CRP that's only slightly elevated.
Okay.
What's the likely pathology for each, and why is patient B's treatment so much more involved?
Patient A, the long-term failure with activity-related pain, is the classic presentation of wear-induced aseptic loosening. This is usually manageable with a single-stage revision. You go in, remove the old parts, deal with the bone loss, and put the new ones in.
One operation.
One operation. Patient B, however, the early failure with wound drainage and those equivocal markers, is highly suspicious for a low-grade septic loosening trapped in a biofilm. And the problem here is you cannot eradicate the bacteria while that colonized implant is still in the body.
Which necessitates a much more complex strategy.
It necessitates the preferred two-stage revision. Stage 1 is a radical operation. The surgeon goes in, removes everything, the implant, all the cement, meticulously debrides all the infected tissue, and puts in a temporary antibiotic-loaded cement spacer.
And then what?
Then the patient gets several weeks of intensive systemic antibiotics. Stage 2, which happens months later once the infection markers are normal, involves going back in, removing the spacer, and finally implanting the new definitive prosthesis.
Wow, the complexity of that really underscores how serious infection is. And finally, what's the expectation for a patient having a revision compared to their primary THR?
The results are distinctly not as good as a primary replacement. The complication rate is higher, particularly the risk of dislocation, because the tissues are scarred and the muscles are weaker. This is why specialized components, like dual mobility implants, are often needed in the revision setting to try and improve stability. #tag outro.
That was a really comprehensive deep dive into Chapter 39 of Baily Love. We've synthesized the anatomy, the biomechanics, and those complex surgical decision paths. We've anchored the critical facts. The hip withstands up to 10 times body weight. Its lifeline is the medial circumflex femoral artery, and early AVN demands an immediate MRI.
And remember those clinical anchors. The Trendelenburg test is a measure of abductor muscle force fighting gravity. And when you're treating OA, teaching the patient to use their walking aid in the opposite hand is a powerful biomechanical intervention. We've given you the roadmap. Your mission now is to dive back into the full text for complete mastery.
We discussed how femoroacetabular impingement, FAI, is now believed to be the underlying cause of so much of what we used to call idiopathic osteoarthritis. We also know that revision surgery is complicated, it's expensive, and the results are substantially inferior to a primary replacement.
And that leads us to our final provocative thought for you to consider. Knowing the catastrophic long-term consequences of these structural pathologies like FAI and understanding the steep price paid for revision surgery, how dramatically will surgical strategies shift in the next decade to prioritize complex hip preservation procedures? Things like advanced arthroscopy and precision osteotomies to ensure that total hip replacement becomes a true last-ditch resort, even for middle-aged patients. Think about the implications of investing in prevention versus simply treating the inevitable mechanical endpoint.